the 2006 International AIDS Conference, Time to Deliver, brought to you by KaiserNetwork.org.
The regions. And since we have five panelists, one more panelist will join us, I would like immediately to start presentations because we have wonderful panelists today. And we will try to listen to presentations first, to keep questions at the end, and to keep debate at the end so that we still have time for sharing our ideas. And the first speaker that I would like to invite to speak is Mauro Guarinieri, and it's my honor to present him. He's interim chair of the Global Network of People Living with HIV/AIDS. He's member of AIDS 2006 Conference Organizing Committee, and he works for International Harm Reduction Development Program at the Open Society Institute. And he's member in a number of organizations, in steering committees, etc. He was involved in many activities related to HIV treatment for injecting drug users, starting from training in Eastern Europe and also providing technical advice to WHO. And Mauro, the floor is yours.
Thank you, Raminten. Thank you for inviting me for the satellite. As you know, hepatitis C is extremely prevalent in drug users, not only injecting drug users, but drug users in general. And in most of the country where antiretroviral treatment is widely available, end-stage liver disease is becoming one of the first cause of deaths, non-AIDS related deaths, but in a way we should start considering hepatitis C an AIDS-defining illness. Most of the people wait in waiting list for a liver transplant, and just as you know, at the beginning was custom to give HIV patient a face or to show what it means to be in a terminal stage, and this person is probably a former or current injecting drug user. This person is probably on a waiting list in a few countries where drug users or HIV positive person can have access to a liver. And this person was probably diagnosed for decompensated end-stage liver disease or hepatocellular carcinoma 6 or 12 months ago. So it's an horrible death, which is way more common. So in a way, we see in countries like in Western Europe or the United States or all the countries where antiretroviral treatment is widely available, we see the future of most of the countries, especially those regions and countries where HIV is more prevalent among injecting drug users. So the question is, first is whether Hep C is a real epidemic, whether Hep C is going to increase in the future years or to decrease. And the answer to the first question is yes. Hep C is a real epidemic, an estimated 200 million persons, but it is a very conservative estimate, are chronically infected with HCV. 3 to 4 million are newly infected every year. Other estimates is probably this number should be probably doubled. And the vast majority are unaware of their status. They don't know they're HCV positive because testing is not widely available, it's not very common, and referral from HIV centers to HIV testing is not that common. So probably more than 80%, or certainly more than 50%, don't know they're HCV positive. And it is the leading cause of chronic liver disease and the leading non-AIDS cause of death in co-infected patients. And the mortality is expected to triple over the next 2 decades, or probably even more. And in co-infected patients, we'll see that this number should be probably multiplied by 5. And transmission is strongly associated with intravenous drug use, but not only, because HCV is much more efficient in a way than HIV, and transmission can be also related by sharing a straw or by backloading, or by sharing the equipment that you normally use when you prepare the drug, which is an information that is sometimes available but not always available. As you can see, the prevalence in different regions of the world matches more or less the region where injecting drug use is the main driving force behind the HIV epidemic, with the only exception of Africa, where probably transmission more related to reuse of needles in the hospital settings. But as you can see, in Eastern Europe, we have 10 million estimates. In Southeast Asia, 30 to 35 million. So it is a big, big epidemic, and it's not going to decrease. In some countries, like in Thailand, recently we reported 92% of incidents in injecting drug users. In some region of China, almost 100%. So it is a real epidemic, and is really related to specific populations that are most vulnerable and more exposed to diseases and lack of support and treatment. Transmission is, as I told you before, is related to contaminated blood. And prior to 1992, via transfusion, is now as more to needle sharing or sharing equipment, or again, straw or other equipment used during related to drug use. Sexual transmission is not very common. It's more common when people have multiple partners, but is still debated. And of course, there is a high occupational exposure, and vertical transmission more common in the case of co-infection. And before 1987, clothing factor were related to HCV transmission, but now this problem has been fixed, and it's very uncommon to see transmission among this kind of transmission. As you can see from this slide, hemophilia is more related to clotting factor. Injecting drug user, these are data from the United States, almost more than 80%, and then decreasing from hemodialysis, sexual transmitted diseases, general population, pregnant women. So it is clearly an infection that is happening in injecting drug users. The natural course of the disease is normally 15% spontaneously clear the virus. In 20% of the cases, they develop cirrhosis, usually over many years. That's in case of monoinfections. 5% of the total will develop an hepatocellular carcinoma, and from that point, the survival is expected to be between 6 months to 2 years. This number has to be multiplied by 5 in case of co-infection, because it's proven that in HIV is speed the progression of HCV by at least 5-fold. And this is not a situation going to get any better in the future. As you can see from these slides, and these are again data from the United States, we expect an increase of almost 600% of, in terms of the need of liver transplant, almost 300% of decompensation, an increase of 300% of liver-related deaths, an increase of almost 100% of hepatocellular carcinoma, and 61% of cirrhosis. So we're going to see a major outbreak of in the following years, and this is expected to happen by 2008. Considering a time span which is more wide than that, you can see that the curve is going to increase and probably going to reach a peak in 2019. So this is a real epidemic, it's going to increase, and a lot of people are at risk either of getting hepatitis C and to die in the future if some decision or not, or treatment is not made available. In terms of co-infection, as you know, co-infection is much more an issue than mono-infection, and HCV is much more prevalent in HIV-positive individuals than in the general population. In the general population, the average is around 2%, but in HIV-positive individual, on average, is almost 20%. This is, of course, related to injecting drug use, and there are still other possible causes that some explained, some unexplained. But it's true that HIV and HCV are two diseases, viruses. They're going to compete, and the more you treat one virus, the more the other virus will prevail. I'm a person living with HIV since 1984, and I have also hepatitis C. And of course, it doesn't apply to all my friends that live in countries where antiretroviral treatment is not available. But all my friends that live in Italy or in the United States, in the last 2-3 years, I can tell you that most of the deaths were more related to hepatitis C than to HIV. And this is due to the fact that, of course, the more you are able to control HIV, the more you have time to see hepatitis C progressing and people dying for hepatitis C. So the reality is that in terms of co-infection, that HIV both accelerates and increases the risk of progression. There are conflicting data about a possible interaction between HCV and HIV. Some studies say that it is possible that HCV has an effect also in the progression of HIV, but still these are not conclusive data. But it's absolutely certain that HIV accelerate and increase the risk of HCV progression, which is a good rationale to push for the inclusion of hepatitis C, or at least hepatocellular carcinoma as an opportunistic infection, or even an AIDS-defining illness. And you can see from this slide that, and this is study data from France, over time, in 1995, of course, most of the people were dying for HIV or AIDS-related mortality. In 2001, most of the people, were dying for liver-related mortality. In terms of treatment, as you know, the standard of care is a weekly dose of pegylated interferon with a daily oral ribavirin for 24 to 48 weeks. And that's the standard for co-infection, 48 weeks or more, with 2 checkpoints at 12 and 24 weeks for early viral response or viral response, with some very debilitating side effects, especially depression and anemia. In terms of effectiveness, in mono-infected individuals, 30 to 50% have sustained viral response. So over time, they can clear the virus, and they're fine after the treatment. And for genotypes 2 and 3, the rate is even higher, close to 80%. In co-infected individuals, of course, the results are much worse than this. The overall sustained viral response is between 27 and 40%, and genotype 1, which is unfortunately more common in Western Europe, in United States, and more common in, for some reason, among injecting drug user, the response is very, very poor. But still, there are reasons to treat people because of the risk, especially in the presence of HIV. And there are a lot of studies showing that even when the treatment is not working, the treatment may also slow progress and reduce risk of liver cancer, regardless of the sustained viral response. So there is also a reason to treat people with or without a sustained viral response. And most of the reason why people are not treated are because they're not adhering to appointment, active substance users, for active psychiatric condition, medical contraindication. The good thing is that the majority of those reasons are related to potentially modifiable psychosocial factor leading to non-treatment. So in terms of challenges, well, the first one is that the successful treatment rate response is much lower in the community. This is probably related to the fact that in clinical trial, the number of active drug users, injecting drug users is very low, and it's very difficult. Some pharmaceutical companies study them actively excluding the drug users. Some other HIV trial are actively excluding co-infected patients. So we don't have the data. So when we transfer the result of the clinical research into the community, we don't have the same result. One of the problems is that current standards include the presence of progression based on liver biopsy, and it is, of course, a very invasive intervention. Some people are really afraid. They can be ready to start a treatment, but they're not ready to go through 2 or 3 liver biopsy because one is not enough to have a real. So that's also an obstacle, especially in some specific settings. And, of course, many clinicians, they refuse to treat injecting drug users are exactly the population that should be treated because they believe they are not adherent to treatment for a number of reasons. And specifically, they believe that they are not going to adhere to treatment, but as you can see, this is not proven. Actually, a review of more than 7 clinical trials found that drug users have similar results to controls group in adherence and response. They can refuse to treat or they can deny treatment to active drug users because they believe they will become reinfected, but data suggests the reinfection rate is not high enough to jeopardize the potential benefit for most patients. Or they can, and this is one of the more common arguments, that they may relapse because they're going to prescribe an injectable drug, they are going to manage depression in individuals that may potentially have some psychiatric comorbidity, but it's not proven that there is any likelihood of relapse, and even so, it's not proven that relaxing drug use imply non-adherence. So, just to close, I just want to quote this. This is the result, the final statement from the European Consensus Conference. I was involved in the discussion, and at the beginning, the final statement was supposed to be completely against treating drug users. So after a very accurate review of all the evidence, this is the final statement, that active drug users should not be an absolute exclusion criteria, since full benefits of therapy are not compromised, that patients required treatment should be offered opiate substitution treatment, including heroin maintenance where medically available, and if the patient is not ready to stop drug use, any assessment should be made case by case. And this is, to me, just common sense in a way, because saying that people are not compliant, people are not adhering, it's just a false statement. In reality, it is the medical system that should adhere to the patient, and if there are any problem, and there are, of course, problems, the only thing that the medical system should try to do is just to fix it. Thank you very much.
Thank you, Mauro, so much. And now I would like to invite Konstantin Lezhentsev, who is consultant for a number of organizations, including Global Fund projects in Russia, in Tajikistan, for All Ukrainian Network of People Living with HIV/AIDS, for IHRD of the Open Society Institute. He will speak more about cases and practical examples how to make HIV treatment possible for injecting drug users.
Thank you very much, Raminta. And it's always a pleasure for me to present on the sessions organized by Eastern European Harm Reduction Network because of really true commitment through all these years in all conference to highlight the issues that we committed to and use the multiple expertise both from community, medical doctors and scientists to really push this issue forward. So while pushing this issue forward, I would like to present on some experience from our region, particularly from the countries of Russia and Ukraine, and I will stay more on Ukraine, about role of harm reduction services and attempts, model projects on actually integrating the harm reduction prevention, originally isolated services, into whole continuum of comprehensive care for IDUs. So the role of harm reduction programs in comprehensive care for IDUs living with HIV, not only limiting to provision of heart, is quite well announced in policy document, in clinical guidelines, including the WHO guidelines for providing antiretroviral treatment to IDUs that we expect to be adopted by September, and those who are describing the guidelines for doing heart utilization in CIS, former CIS region of Eastern Europe. So it's, and for people doing effective and comprehensive harm reduction programs, it's quite obvious that outreach strategies are a vital component of HIV care, getting proximal to the patients, getting all information, treatment literacy, initial motivation to treatment, right on the spot where you meet the patient. Experience of prevention programs is vital for treatment literacy work, developing motivation, and breaking myths. Myths that usually are the main barrier for people to turn for the treatment. And harm reduction actually is a front line in a continuum of care for IDUs. So starting from the standard kit of prevention, counseling, treatment information, going beyond to more higher levels of integrated care approach and trying to concentrate maximum needed services for particular patient IDUs at one setting. And harm reduction prevention intervention should be available at each stage of care for IDUs. And this is a very important thing, because while we are speaking about integrating harm reduction and treatment, we speak about how we can get treatment message, treatment knowledge to harm reduction. And we forget that people are not taking illegal drugs in vacuum. People are going to work, people are starting treatment, people are changing their decisions, and the fact that the person using drugs are coming to the level of starting heart or doing any other medical intervention or getting other services, it doesn't mean that at a certain point he will not get back to injecting drug use, and he's still in need of prevention facilities that should be available on each side. So, and for me, also this announcement that you hear quite often about the treatment and prevention, you cannot permit this artificial disintegration of these things. It's one single action against the epidemic. And I think particularly in comprehensive care for IDUs, this is very practical approach. Integration of harm reduction, originally prevention service into care and treatment is the really practical example of getting treatment and prevention working together. So in Ukraine, based on all these theoretical, practical model principles, we decided to use this and somehow to start this process of integrating harm reduction projects, originally very prevention oriented, very isolated, into this continuum. And there were a number of preconditions for this. First of all, it's launch of 7 substitution treatment project sites in Ukraine in 7 regions with buprenorphine. Previous effective scale-up of IRV treatment programs, and this is thanks to the advocacy from my comrades from All Ukrainian Network of People with HIV and International HIV/AIDS Alliance, primal recipient of Global Fund in Ukraine. Also, it's a care and support component, which All Ukrainian Network of People in HIV was advocating and designed and implemented, that it's not only priority to provide IRV it's also the whole continuum of care should be available, including adherence support, social services, home-based care, and this care and support component was already in place in these regions. And also we were using the loophole for scaling up substitution treatment because still it was not totally green light for going on for substitution treatment. So first, methadone was demonized, and there was option only for buprenorphine to start as a pilot, and the reason was actually to limit it as a adherence tool for IRV treatment. So it was originally pushed to integrate. And at the same time, with all these positive sides there, I would like to say that in my region, Eastern Europe, it's historical isolation of most of harm reduction projects from care and treatment activities and more focused on only very narrow vision prevention activities. So the integration, as it's called, the main objective of it was to ensure proximity of IDU care projects by establishing link between harm reduction and IRV substitution treatment projects in one region, and try to introduce the case management model and patient outreach model. So what is in integration, what we proposed as a program? We made our first official study tour of multidisciplinary team of drug treatment doctor doing ST, IRV doctor, team of outreachers from harm reduction and peer counselor from PWA community who is working in the AIDS Center on Adherence to Yale. And I would like, most of you maybe know community healthcare event program of Yale Medical School. This is quite good model of integrated care of TB, HIV, harm reduction, and ST care. And we made a follow-up IRV for IDU trainings, meaning basics of IRV antiretroviral treatment for injecting drug users for outreach teams. So each people who were originally working on prevention, doing their very good work, having trustful relations in community with prevention message, we gave them the basics about IRV and particularly focus on IRV specifics in injecting drug users, meaning interactions with substitution treatment, interactions with illicit drugs, best models, etc., and motivation and how to break the myths, main myths in the community about treatment. And then we made a small grant, as I call integration kit, salary for outreach workers, upgraded salary for those who are experts also in treatment literacy, mobile communication, transportation. And we were going on follow-up technical assistance with regional and international technical advisors. So 6 months passed, and in this scale-up process of substitution treatment, which was going very low, we managed that people who were working in outreach team really brought the people from outskirts, the people who 5 years ago got their HIV diagnosis in the AIDS Center, signed the criminal responsibility paper and said, I would never go back to this place, I would live somewhere in my place and do my business and will not talk about this. But outreaches were the key people who could get to them, and they were able to deliver this message and bring these people into this continuum of care, community center, substitution treatment, which mean you see quite a big figure, so 130 in Odessa, that's the cities of Ukraine. Odessa, Simferopol, Donetsk, so, but you see also dropout rates. And this is the very also important fact. It's a very negative fact, but also it's a very important fact. I do remember when the IRV was starting to scale up, lots of people were telling, okay, we are providing the medicines, where are the patients? So in this case, nobody can say that we do not need to scale up substitution treatment, because there is no patients. There are patients, they're in waiting list, and people are dropping out. By dropping out, I do not mean that people are completely lost to follow-up, but people lost this feeling of continuum of care. People lost this feeling of being adherent to other people who could give them counseling, who could break their myths, who could maybe solve their some legal problems, etc., because they have frustration, because they come to the treatment that they really wanted for years, and then they couldn't get it because of no scale-up. Key problems of scale-up. Low rates. There was no price reduction for buprenorphine done by the main primal recipient. It's still monopolization of the market. It's only one company who provides this, and it's $219 per patient per month, which is incredibly big price. It's still lack of understanding of harm reduction role in treatment by harm reduction establishment. By establishment, I mean the managers of harm reduction project. They're not so motivated to actually support this thing and be the leaders in getting integrated, because it's They still have vision of clear separation of zones of users. Here is our prevention, here is your treatment, and it's a monopolized area. Harm reduction is doing harm reduction, assessing themselves, monitoring themselves, and putting the results themselves. So it should be broken. And absence of clear vision of case management. Case management is usually mixed up with outreach work, home-based care. So this model of case management, of taking person out of marginalized side and bringing him to care, getting him accommodated there, and then going for another one, is not yet installed. And historically undeveloped outreach component. It's lack of investment into people, into community. So how to solve it? Strategic directions. It's scaling up access to treatment of ST, access to methadone and All Ukrainian Network, and our program, and Clinton Foundation and Ministry of Health of Ukraine is really working hard on very quick registration. We are now in process of registering 2 forms of methadone from 2 companies. Expanding standard kit of harm reduction, so not only needles, but also TB screening by PPD, treatment literacy, case management. Flexibility, response to illicit drug market changes. Harm reduction in our country is still working on the principles of opiate, poppy straw use that was 7 years ago. And now it's a huge wave of amphetamine use, powder drugs are coming on the market. People have different needs, people have different social classes, people are mixed up with other cultural patterns, dance music and all other issues. Younger generations, so we need younger outreachers who can come to them. So harm reduction should not be stable, should be flexible. And the key point I would like to say is investing into people, not in the infrastructure. We need to, when I say strengthening outreach component, it's investing into people, into making community experts, expert in treatment, expert in social care, expert in case management. So I would say that based on this small, quite pilot experience, we revealed a number of key challenges that I would say have influenced a lot, and were advocated a lot by All Ukrainian Network and other partners to get full reflection in the Global Fund Round 6 application. So these lessons learned during this period, I think, are reflected quite well in this application. And most devastating effect, it's also like a lesson for myself, or the most devastating effect of the artificial separation of prevention and treatment has been revealed when faced with the challenges for organizing comprehensive care for IDUs. Because when we say the harm reduction is not integrated, it doesn't mean that some 2 trends are not working together. It means that we do not outreach to people who need care most of all. And now I will not speak too much about Russia. I would say that we're starting the same process there. It's quite successful implementation starting on IRV component in Globus. It's Global Fund 3rd round in Russia in 10 regions. So we're also providing international technical assistance, mentoring visits. We prepare peer experts who are working in the 8 centers as part of multidisciplinary team, and we are trying also to make a study tours to best model sites of integration. So situation in Russia are very much the same as in Ukraine regarding the harm reduction motivation, integration into care activities, commitment to this role. It's quite the same regarding the establishment of harm reduction project. However, there is no substitution treatment component, which actually put more burden on harm reduction and more responsibility to take care about the people. And there is already good experience, I would say, before even project in Kazan, Orenburg, and St. Petersburg. And I just will not take a lot of time and would say that Sasha Volgina will also follow up and say more about practical problems, as she's the key person who's visiting the sites and assisting me in getting the full feedback and assistance to this. Thank you very much.
Thank you, Konstantin. And just before giving the word to Sasha Volgina, who was already presented by Konstantin, I wanted to ask whether Alex Vodak is with us in the room, and if yes, please join us in the podium. So the next our speaker is Sasha Volgina. Some of you might also visited today's satellite meeting in early morning, where Sasha Volgina was also speaking about issues in Russia. And now this presentation will be more practical and more in details what is happening in Russia.
So, well, I will talk about access to the treatment and what it means now in Russia. And so the access to the treatment means that sustainable and regular medicine supply, and which is very important now in Russia because the last months the situation became really worse than it was before because of the interruptions in the treatment in many regions of Russia. And so it's the first step about the access to the treatment. It has to be a sustainable and regular medicine supply. It's access to information about its availability, treatment literacy, and comprehensive approach to care, support, and adherence. And which is very important also in Russia is that all that measures have to be provided on non-discriminatory basis, with special attention to specific needs of marginalized groups, particularly IDUs. What is declared nowadays in Russia? That there is a problem of HIV, and there are people living in HIV/AIDS, and they are mostly drug users. Government and society admit now that HIV exists in Russia, though it's still not accepted officially that we have an epidemic. And there are people with HIV/AIDS, and there are drug users, and before, actually, we didn't exist, as it was with sex in former Soviet Union. It exists, but the fact was not admitted officially. That there is a treatment, and that people living in HIV/AIDS have a right to it. Now it seems wrong to say that IDUs are social and productive, and there is no reason to treat them, as it was said before. And nowadays, there is a political will. So government admit that it is their responsibility to provide this treatment. The budgets devoted to solving this problem had been increased in 20 times if we compare with previous years. So-called Putin's federal money or National Federal Project Health is responsible for that funding. It took several years to work in advocacy to make these declarations too. I think that situation was changed because of the two main factors: strong advocacy wave inside the country, right up to creating such radical movements as Front 8, and international from outside help and pressure at the same time. Global Fund working in the country, and G8, things like that. So that was the declaration. And what is the real situation now with access to the treatment? I mean, our supply without interruptions. Before, the local budgets were providing some not really big budgets, but still there were some people who were getting treatment from the local budgets. When it was announced that the federal project will start, these local budgets were closed, so that they are waiting for this federal money. And this project haven't, just started, but it's not working actually, because there are, because of the number of reasons, such as procurement problems, tenders that didn't pass for a number of drugs, there's no expertise in planning, forecast, delivery, and of course there exists corruption. So when we speak about access to treatment, we must speak first about sustainable supply of medicine to the regions based on their needs. And the only regions nowadays that have sustainable IV delivery are Globus regions. And actually, the last thing I was doing when I was leaving for this conference, I was sending the antiretrovirals to Kaliningrad city to people who have interruptions in it. Our task as activists is to be watchdogs in the process, to gather facts and act as witnesses to the reality of treatment access. But if we look at the treatment in the regions, even in global sites, we see a number of problems with implementation after the drug supply is ensuring. And we should be proactive and use the experience to prevent negative practices in national projects realization before it will be started. So here are the main barriers to IDU access to treatment on the ground. It is the specific of medical infrastructure, stereotypes of AIDS center work. Main priority is still control of epidemic, whatever it means. Focus on epidemiological data, collecting statistics, reports about situation with AIDS. So in some AIDS center, there's like 6 epidemiologists who are actually forgotten how patients look like, and 1 clinician. So calculation of cases are going well. And also the other problem is like low salaries, burnout, and poor motivation to treat anyone. A totalitarianistic approach, which was one of the stereotypes of AIDS center works in the previous years when the access to the treatment was really poor, and committees that decide to treat or not to treat rather than how to treat effectively. And at the same time, infectionists, unlike their colleagues from narcology sector, are sharing ideas about need of substitutional treatment. However, they're still part of the system, and they could not be vocals only after permission. Talking about the patients, usually they have a very negative experience of interaction with any state institution. Usually it is the most motivated group to work with IDUs is police. So due to this motivation and sincere feeling, so the practice of universal referral sites. So the main referral system nowadays is referral to the police when the people are entering any state institutions, starting from pharmacies and ended on the AIDS centers. Usually the first experience of contacting healthcare institution is very negative. Healthcare providers refuses to treat drug users, discriminate against them, and report them to the police. IDUs is an isolated group, so they have very of seeking help of any kind. They don't believe that they have any rights or that fighting for their right could help them. I was talking about this case in Kaliningrad. This person, he was changing the antiretrovirals for the 4th time, and he's saying like, I'm not going to talk about that officially, and I'm saying because the situation could become worse, and actually the situation can't become worse. Now it's already too bad. So it's hard to spread information among IDUs, and often there are a lot of myths. And for instance, such myths that antiretrovirals are clinical trials that will make people sicker, or that antiretrovirals are addictive, and like millions of them. The other barrier to the access to the treatment is that there's no any adequate drug treatment support. In order to receive free drug treatment, you must be registered officially. So treatment is limited to detox. The waiting period for this treatment can be as long as 2 months in some regions, and there are often long waiting lists. Substitution treatment is illegal in Russia, and rehabilitation is usually expensive, more than $1,000. Free rehabilitation is provided only by religious groups. Narcology is a corrupt profession, and narcologists are more interested in making money than in providing effectiveness treatment or reforming the system. For them, the failure of the treatment only means more profit. In innate groups, HIV is very stigmatized, and those living with HIV are not able to disclose their status. Also, there are specific or the stereotypes of harm reduction projects works. The heads of the harm reduction projects sometimes are, well, usually are the heads of AIDS centers or narcologist departments. That's why, well, they have all the specific I was talking earlier. Also, the salary of the outreach workers is very low. They are not taking part in any decision making, and that brings to really hard burnout syndrome. And also, of course, they have the problem with the drug use. And the other barrier was the problem of accepting peer counselors as equal members of healthcare team. That really took a lot of time and to work that out, but nowadays I think that the strategy of involving peer councils is really working already. And the other thing is this coordination among key stakeholders and healthy competition between these institutions. So the main problem now in global fund regions are that clients are not looking for help and low level of adherence among those starting treatment, high dropout rates. And these problems are not surprising when we work with such hard groups of patients as IDUs. So people even don't know that treatment exists and it is available. Fear and myths about antiretroviral, lack of trust over their sensors, are a system that pushed them away since the first day of diagnosis. Patients who start treatment do not receive adherence support that considers the special needs of IDUs. So key problems are related to the needs to get information about treatment to marginalized communities, the lack of case management model, and the lack of intervention for adherence support and care for people starting treatment. It is really important to speak about these problems now, rather than simply report about the good indicators or showing good models. We have to talk about that now, so that when we will start to work out the national models, we'll have already that experience. So what is the current activities now? Informational walk-in trainings, and the last training that was held for peer counselors and outreach workers was very practical training on consulting burnout, post-test counseling, increasing treatment uptake, and supporting adherence. Increasing funding for treatment programs, peer counseling and outreaches, and also technical assistance through the site visits. One of the main things I think is monitoring, documenting patients' needs as a tool for advocacy, future advocacy, and monitoring the inclusion of peer counselors and outreach workers in the design and implementation of the programs, as an expert advisors who improve program effectiveness. And also the other part we need to work more, and we are working already, is advocacy, spreading information about this work. And Minister of Health showed interest in reforming the treatment system and has supported peer counseling and speeches. Still, where we are going from now. We reach political will not through organized advocacy strategy, but through desperation and anger. We hope for collaboration and partnerships to make treatment effective and available for all. To get over the existing barriers, we have to get back to our basics. And it's not a matter of beginning for reforms to permit us to stay alive. Staying alive is our policy of immediate and radical changes in the system by all methods. Thank you very much.
Thank you, Sasha, so much. And now we will move to Asian region. And it's my pleasure to invite Karen Kaplan, who is co-founder of the Bangkok-based Thai AIDS Treatment Action Group, TTAC, whom we know very well usually. She's their Director for Policy and Development. And Karen worked in HIV, AIDS, and drug field in Thailand since 1988. And even before that, she was working also in the US in that field, so she's really veteran, as we call it in Eastern Europe.
Oh,
Okay.
She looks quite young.
But she's
thank you. So actually, it was supposed to be someone else speaking here today, but ironically, or not, he will be starting hepatitis C treatment in a couple of days and is preoccupied with that. And he himself is a former injecting drug user. Do I control the slide? Sorry, I don't know how to. This? Oh, thank you. As we all know, ARV has changed the face of AIDS. It has drastically reduced mortality and increased people's quality of life. In Thailand, the recent introduction of ARV and rapid expansion has led to a 50% reduction in mortality, HIV-related mortality. There's also been a record commitment of funding over the past years through the Global Fund, allowing many countries to scale up access to treatment. In a recent UNGAS progress report, treatment was described as an unprecedented opportunity for national responses where care, prevention, and impact mitigation efforts delivered in comprehensive and mutually reinforcing manner. And universal access, which is now the banner under which we're all working, has really lofty goals of 80% coverage of treatment, reduction of new HIV infections by 50%. And regarding injecting drug users, a leading expert from the WHO, sitting somewhere here, I thought I saw him, said that there is no reason that IDU should be, there's no excuse for excluding IDU from life-saving drugs. However, moving from rhetoric to action has not been an easy road. This morning, for those of you who saw Chris Byer's plenary speech, you saw that of the 13 million plus injectors in the world with HIV, we've got about 34,000 on ARV, 30,000 in Brazil. And so I think the failure of treatment is also a reflection of our failures in prevention to date. For IDU, often we face even the minimization of the importance of treatment for IDU, even the existence of IDU. In Thailand, as they see a new methamphetamine epidemic, they're just ignoring the needs of IDU that have been present since the late 1980s with 50% prevalence. That's the only group that hasn't gone down since then. And the approaches that we know are proven to improve the quality of lives of people who use drugs are under attack. Harm reduction is a dirty word at the UN and for the United States government, our biggest funder of AIDS-related projects, and this is unacceptable, and we have to fight this. It's ironic that we're excluding vulnerable groups, injecting drug users, and not thinking about them from in our plans to improve access, because we know, I know this is a disgusting and unsavory word, but we've got reservoirs. If we don't address IDU epidemics, they will continue to be there. It's like the same with Burma in Thailand. They try to ignore it, but what we know about Burma is that it's the source of 4/5 of China's HIV/AIDS cases. It's the source of most of the world's HIV strains. We can't ignore these groups that some people would prefer to go away. The problem is also the human rights situation, that we are undermining our efforts by not paying attention to the human rights environment, the legal and policy environment. We're pouring money into harm reduction or quasi-harm reduction projects, and at the same time, we're not talking about the need to repeal criminalizing laws and policies. Also, we are not bringing up the human rights obligations to balance our efforts to repress drugs, which is a problem in the UN drug conventions already, balanced with our public health efforts. We need to look at the UN conventions, and we need to pay more attention to the human rights principles that should be underpinning our work. But there's a huge faction that's moving against these very principles, and we have to pay attention to them too. It is unacceptable that I heard that Peter Piot refused to utter the word harm reduction to the General Assembly twice in New York last June. Our punitive approaches are actually increasing HIV. We know that by sending people to jail, we increase their risk of HIV, we increase their risk of multi-drug resistant TB, and we totally undermine their ability to have fulfilling lives, get jobs afterwards. People have terrible times coming out of prison and often go right back to using drugs. I know this is not a problem that's easy to address, and I live in a country now that doesn't have a whole lot of money. It has more money than some of the least developed countries, but regardless, there's always money for military, and there's very little money, interest, or capacity to put money into health. And then you go down from there, HIV/AIDS has even harder time to get funding or interest from the government. And then we get to drug issues, which are never seen as health issues. They're seen as drug enforcement, law enforcement issues. And so it's rare to get money for the kinds of things that we're talking about here today, access for treatment for drug users. And of course, politicians get a lot of political mileage from focusing on national security and stepping up, the tough stance on drugs and zero tolerance. In Thailand, I spoke about this morning, the literalization of a drug war that left thousands of people murdered by government-sanctioned measures to control drugs. And HIV still runs rampant, and no one is speaking out for drug users. What we know this morning, we already heard from Konstantin and Sasha and everybody here, the kinds of things that we need to reach drug users. But again, those things are being undermined. Needles are not promoting. We have countless studies from hundreds of cities across the world that show needles do not promote drug use, but they do prevent HIV infection. Yet many funded projects are unable to implement these kinds of interventions. Quality evaluated drug treatment is still missing in many countries. It's illegal in some places as well. People can't even get therapy because methadone is not considered therapeutic. It's considered an illegal substance. User-friendly services. Treatment is typically meted out it's punishment in the guise of treatment. We have methadone tapers, forced detox, supervised urines for methadone clients, all kinds of things that humiliate and undermine any possibility for equality in a patient-client-patient, doctor-patient relationship. We're also seeing now with the advent of ARV scale-up, this criteria that's non-medical, in assessments that go on about the ability to adhere to the ARV. We have limited resources, we have limited ARV, so we're going to look at who deserves the ARV. In some places, they actually have exclusion criteria if you're a high-risk behavior person. The doctors are afraid that they're going to look bad if their patients don't succeed. They don't want to waste their budget. Drug users are immoral, bad people anyway, and they don't deserve these high-tech treatments. And they'll spread infection if they don't adhere and spread superinfection. And all of this is an assumed attitude. So the kinds of things that, let me just move on, sorry, I know we have very little time. Some of the urgent issues that we have to look at are simply educating more and more people, whether they're our AIDS organization allies who often don't understand harm reduction issues. We can't expect people to just understand them without spending time on informing people about the benefits and dispelling myths that my friends here discussed about harm reduction and ARV for IDU. The media, public, stakeholders, everyone needs to learn about harm reduction so they can advocate for it and advocate for the human rights protections that we need in order to effectively implement harm reduction. In Thailand, they're taking things like peer outreach, benign activities that they like, at the expense of needles, as if you can pick one without the other. It demonstrates a total lack of understanding about how all of these interventions fit together. And it also puts drug users out into the streets without any protections from the law, from the police, expecting drug users to do the work of bringing in clients without thinking about their own needs. This is why we want drug users to be involved, because they are the ones who care the most about their communities, but not be used by AIDS programs. Drug users don't only think about HIV or think about reaching out to their peers only about HIV. Often they're not thinking about HIV at all, and it's not our business to force them to. But the kinds of advocacy things that I think weren't mentioned yet, but I think are important, thinking about IDU and ARV, are the lack of attention to things like Hep C, which Mauro talked about very importantly. The person who was supposed to speak here today has Hep C and didn't know that having a Hep B vaccination would be really helpful. A Hep A vaccination would be really helpful. ARVs, while we say that drug users, injecting drug users with hepatitis can tolerate the existing first-line therapies in developing countries, which is essentially like D4T, 3TC, and nevirapine, even though we know nevirapine is hepatotoxic. The truth is, in other countries, in richer countries, we see different first-line regimens. Why shouldn't poor people have the same access as rich people? And we hope that we can see generic treatments of all kinds for hepatitis C, for ARV, reaching the people when there are 35 million hepatitis C infected people in Southeast Asia. There are also a lot of HIV positive people, and these treatments are urgently needed. So finally, the kinds of things that we can do is to support drug users directly, to help us understand how to develop effective programs, and to work with the UN. One of our biggest problems at the country level is that there is literally no capacity. There is no one in the UN, practically in UNAIDS and WHO, who are experts on harm reduction, who can be there when we need them to review methadone maintenance guidelines that are coming out in Thailand, for example. Why is Geneva not focusing on this? Southeast Asia has an IDU-driven epidemic. Let's see a little more investment by the UN. Or is there dissonance within the UN that we also have to be talking about the need to repress, do drug suppression and demand reduction, and then to promote harm reduction on the other hand? I don't think that that's been resolved. We need to work with more NGOs, and we need to work with governments to see the value of providing treatment to all. And that we need to raise our voices about these issues. This is not meaning that we have to be angry, but when you're watching people die and get sick, when other people are starting to have more and more access to more and more services, we can't talk about equity until we're thinking about people who use drugs, migrants, men who have sex with men, and all the very people who have been most deeply affected by HIV to begin with. Thank you.
Thank you. Thank you, Karen, and thank you to all wonderful panelists who fed us with what are the challenges, what are opportunities, and what are the practical models how to deliver HIV treatment to injecting drug users. And thank you also to panelists for keeping the time, because now we will have almost half an hour for questions, comments, and discussions. Please use microphones. There are 2 microphones, one over there and another over there. Oh, 3 not even mics. Please, Henning.
I'm Henning Mikkelsen from UNAIDS. I want to congratulate the organizers for making this very important session here. I think this issue is extremely important, especially, of course, in the countries where large numbers of the people who are living with HIV are also injecting drug users. We see the situation very seriously, especially in countries like Russia, a little bit better in Ukraine, but we have still a long way to go to make sure that there will be universal access to treatment also for people who are injecting drugs. So this is very welcome. From the last presentation, I will take back to the UNAIDS family the call for better capacity also at country level within UNAIDS to assist this. I just want to say a little bit about our positions on on harm reduction, which was also commented there. I think it's important for you all to know that both in the Declaration of Commitment, which was agreed by all the member states of the UN back in 2001, and also in the recent political declaration on AIDS, which was agreed at the high-level meeting in New York, there's a very clear and explicit reference to the need to intensify efforts to prevention programs, including harm reduction. What is missing in the political declaration from this year is there's no explicit reference to substitution treatment. This is, from the viewpoint of UNAIDS, regrettable, because we published a new a policy paper on prevention called Intensifying HIV Prevention, and there we had agreement from all the countries and civil societies who are part of our program coordinating board that there should be a strong call also for harm reduction, including also substitution treatment. So this is very much our policy line. Peter Piot, when he spoke at the Regional AIDS Conference in Moscow in May, there was also very explicit about his support for harm reduction, including substitution treatment. He's very vocal on this currently, and he has always been, I would like to say. Thank you.
Thank you, Henning. And we will take 2 more questions and then go back to panelists. And also, I wanted to mention that there is possibility to pass questions also using cards, which volunteers have. So you just approach them and they will help assist you. Okay, please.
Thank you. I'm Urban Weber from the Global Fund. I have a question to Sasha. Background of this question is that there is one grant in Russia from the Global Fund, which is referred to as the Globus grant, which is a more or less HIV prevention program, which has a little treatment component. This grant will bring up to 4,000 people under treatment, but there is also a second grant of the Global Fund to Russia, which explicitly is a treatment grant, and over 5 years, this grant will bring 75,000 people under treatment. Now the question is, what is the strategy of the Russian Harm Reduction Network to ensure that the appropriate proportion of drug users are getting treatment under this second grant?
Thank you. And then we will have the next question and then go back to
My name is Bruce Marshall. This question is perhaps for Mauro. HIV has been around for 25 years. I graduated from medical school in 1978, which predated the appearance of HIV disease. And in those days, we talked about this non-A, non-B hepatitis. So it's been around for longer than HIV disease. There are 3, 4, perhaps 5 times as many people in the world infected with hepatitis C as are infected with HIV disease. There are 20 antiretroviral medications available to us now, and a multiplicity of different therapies, yet there are only 2 anti-hepatitis C drugs and only 1 particular kind of therapy, and it's not very satisfactory at that. And I was just wondering, Mauro, if you'd like to comment on those differences and the fact that though hepatitis C has been around so much longer, so many more people are infected, and yet not much development has occurred in the way of hepatitis C therapies.
Thank you so much. Mauro, would you like to start?
Well, I believe that one of the reasons that we see a dramatic increase of deaths related to Hep C in some countries, I think this is the future for all the countries that are introducing ARVs right now. And of course, there is little research. There are some new treatment, new protease inhibitors in the pipeline. There are some options for the future, but I think there's probably little interest. It's true that in mono-infected, mortality is not that high in HIV co-infection, and for many years, Hep C was not a priority because simply people were dying for AIDS. The urgency was just to treat, but it's certainly great need for new drugs. especially drug that can offer a real, a much higher rate of success, especially for co-infected individuals, especially for genotype 1 and 4. They are more prevalent in most of the country in Asia or in Eastern Europe, and for some reason are more prevalent in injecting drug users. One of the problems I want to mention that recently the problem of the inclusion of the population are most in need of those treatments. The injecting drug users are proactively excluded from most of the trials. Recently, Schering-Plough put a very strange exclusion criteria for African Americans in one trial related to the protease inhibitors. The explanation was very strange. Essentially, they were saying that the response rate is different in African American, which is not rational for excluding. So there are this attitude by pharmaceutical company to make their trial look good, but at the same time to make impossible to transfer the result to the real community. Because of course, if you look for a very improbable individual that doesn't exist in trial, then when you transfer the result to the community, you see that the results are very, very different. So there also one of the problems is also to push and advocate for the inclusion of a population that really reflect the people with hepatitis C, and especially for co-infected individuals. It was the same for HIV trial, where in most cases co-infected individuals are not included or not eligible for the trial. So there's a great problem.
Sasha?
Я бы лучше ответила по-русски, мне так легче отвечать на вот вопрос о вовлечении сети снижения вреда в реализацию. Ну, во-первых, я хотела сказать, что я в проекте «Глобус» сама работаю техническим консультантом, вот, и хотела сказать, что этот проект на самом деле добился больших результатов, если говорить о внедрении такой стратегии, как консультирование равный равному. Но да, вот я сегодня говорила как раз о проблемах, которые видны, и как раз если мы говорим о том, что планируется взять на лечение 17 тысяч пациентов, да, 75 тысяч пациентов, то да, вот те проблемы, которые мы уже видим в «Глобусе», когда мы берем на лечение такое количество людей, мы столкнемся с ними в будущем. Вот. Это именно то, о чем я как бы хотела сказать. Относительно вовлечения снижения вреда, я не представляю все снижения вреда. Вот. Просто мы столкнулись с проблемами по привлечению и потребителей наркотиков в регионы Глобуса. И поэтому сейчас одной из стратегий привлечения является вовлечение проектов снижения вреда на данный момент. Спасибо. И второй вопрос. Какую организацию я представляю? Я уже говорил, я являюсь техническим консультантом «Глобуса». И какой источник информации вы используете для искаженного обобщения ситуации по России? Ну, я еще работаю в организации сообщества людей, живущих с ВИЧ. В эту организацию приходит достаточно большое количество писем за последние несколько месяцев о перерывах лечений из очень разных регионов Российской Федерации. Поэтому я не считаю эту информацию искаженной. Спасибо.
Я в этом зале уже работаю переводчиком второй раз.
Okay, I will ask Konstantin to translate because Sasha answered.
I have a huge experience translated in the hall. I would never enter it again. The first question that was a question by Urban about the strategies that harm reduction network has in terms of overcoming the problems existing, especially envisioning the 75,000 indicators for access to treatment in the next Global Fund proposal that is ongoing, starting to go now. And Alexandra's response was, she's working as a technical advisor to Globus on peer counseling, and Globus reached quite substantial, effective model on peer counseling and integrating peer counseling into multidisciplinary teams. But the problem is in outreaching to IDUs, as she said, and for this, the strategic direction is to involve as much as possible, educate the harm reduction projects into this process. She doesn't represent the harm reduction network, and that's why she cannot speak on their behalf, but at the same time, I will add that recently there was a presentation from Russian Harm Reduction Network where they specifically emphasized the need in expanding harm reduction activities and getting more in treatment. How it will be in practice, I wouldn't say I do not know, but from our behalf as a technical assistance, we will do the focus and priority for international harm reduction project to educate specifically this harm reduction component on treatment issues.
And if I may add to this,
Если
I'm not from Russian Harm Reduction Network, but I'm from Central and Eastern European Harm Reduction Network. And as much as I know, in that application, there are 2 other organizations involved, which is very important. And one of them is Community of People Living with HIV/AIDS. And another organization is Drug User Group, Collegates. And I'm sure that involvement of community would lead to much better understanding of needs and much better addressing of needs of people living with HIV/AIDS.
Я переведу Рамин, то Рамин сказал, что и я с удовольствием добавлю это уже, что еще 2 основных партнера и организации — это сообщество людей, живущих с ВИЧ России, которые уже обладают определенными знаниями и экспертизой в поддержке приверженности, обучении, лечению и так далее. И вторая — это группа потребителей, адвокационная группа сообщества потребителей наркотиков «Колодец», который уже внедряет компонент кейс-менеджмента в Москве. И, в общем-то, эта экспертиза будет приветствоваться и в сети снижения вреда России. Второй комментарий Саши. So the next answer to the question that was sent in Russian, that way Sasha prioritized it in Russian, is which organization do you represent and what source of information you use for giving the different situation about IRV in Russian, meaning that Alexandra is giving not exact information, and Alexandra's answer was she's a technical advisor to Globus, to the project of GF Third Round, and but also she's an active member and leader of the community of people living with HIV, and her information is based on a number of letters, which I actually saw myself as well, and those people who are linked to International Treatment Preparedness Group also saw these messages and call of despair from a number of regions of Russia. I can name the regions myself, so I have a full credibility as well. То, что я добавил к ответу, что также те участники международной рассылки, международной группы поддержки лечения получают неоднократно такие же письма из регионов России. Я лично получаю их по этой рассылке, поэтому я могу сказать, что информация приходит непосредственно от людей. Лекарства отправляются для людей, которые прервали терапию, от других людей, в частности, от всеукраинской сети людей, живущих с ВИЧ, которые помогают своим коллегам из других регионов. Вот.
Okay, thank you. And maybe you would like to continue because there are a number of other questions that were sent in these forms.
И мне вопрос, да, действительно. So, and I will speak in English. Okay. So, for Konstantin, could you please address the importance of methadone treatment legality in Russia, and does it vary from region within Russia? So, Sasha maybe can add, but in all our presentations, we say that this is a critical issue for Russia, having this height of epidemic, having substitution be illegal and methadone illegal status in Russia really influences a lot the whole activities, not only in terms of effective care for IDUs, meaning the drug treatment services, and Sasha said about the current status of drug treatment services, but also it's the key issue about IRV access and effective HAART utilization by users. And is this situation vary region from region? My personal observation that as much as we broaden the number of practitioners, medical practitioners outside the drug treatment circles involved into understanding what substitution stands for and what are the standards and guidelines, we can have more and more allies. And we would definitely have more allies, and my personal opinion, from infectionists, from AIDS treatment doctors, and from TB treatment doctors, if the narcology field, drug treatment field stays so much conservative and couldn't be proactive for for advocating for substitution treatment. It doesn't relate to the, for sure, activists and the leaders of scientific drug treatment community from Russia, like Vladimir Mendelevich, who basically defend the right of the scientist and the doctor to educate and to speak about the treatment that is internationally recognized. So the second question is how injecting drug users are getting involved into IRV treatment. The note comes from Ukraine, so I mean maybe people mean Ukraine. By the end of the year, by second GFATM round, so it's Ukraine, right? We should reach the indicator of 17,000. So I said about the case study, what is done. I'm not sure it would be effectively addressed during this period. I said that for the Global Fund 6th round, it would definitely be addressed if the application would be accepted. But how the users are covered or involved, this is my strategy is what I was speaking about, involvement effective harm reduction project. But right now, the big the big involvement for this are done by all Ukrainian network of people in HIV that install the peer counselor community centers that are involving people who are also using drugs. And also the priority of the all Ukrainian network, as was said by Irina during the previous session in this hall, to actually address specifically marginalized communities and people actively using drugs, people co-infected with TB and HIV.
Okay, and Karen, could you address also the question that you received?
The question is, what is the role of drug user community in delivering care to drug users, in your opinion, and in practice in Thailand? And basically, drug user community, there are a lot of drug users in Thailand, but there is one organized group of drug users called the Thai Drug Users Network that organized during the end of 2002. A lot of them were HIV positive drug users who had been leaders in the PWA movement, but saw their issues totally ignored and sidelined, and the government ignoring and sidelining their issues, and they couldn't stand it anymore. In particular, they had been watching their friends die of AIDS, but now through drug wars, they were watching people be even further stigmatized, criminalized, and had to stand up because they felt they had nothing to lose. And basically, what they want to be doing and what they do is to advocate, to be involved in the development of programs and policies that affect them, to have a voice in the places where people are using money to develop programs and policies that control them. And so to make those programs and policies meet their needs and improve their lives. And I think basically that's what they want to be doing. Thank you.
And I have a question from Irfan from Indonesia about side effects and what happens if an HIV and HCV positive person has to stop treatment if there is a risk for resistance. Of course, the answer is yes, if the treatment is to be stopped. But as Karen mentioned before, one of the problems is that there are some drugs that should be avoided when on Hep C treatment. There is a risk for increased anemia because of an interaction with ribavirin. There is, of course, nevirapine is not the best drug. And unfortunately, the options are very limited, especially for poor countries. So the typical first-line combination, especially generic, is not the best option so the problem is, one of the problems is that it's very unlikely at the moment that a co-infected patient in a poor country have access to Hep C treatment because there's no generic alternative, and the treatment is really, really expensive. But even so, there is a problem also for switching the drugs. So we're still on a very early stage. And then I just wanted to follow up on the previous question, because I think another reason why there's so little research on Hep C is also related to, because I believe that most of the research was the result of a lot of pressure by the community. So now we have fast track, we have a lot of drug, not because the pharmaceutical company or the government were willing to produce a drug, but there was a lot of pressure. So Hep C is really affect a group that we're not even sure, are drug users a real community? Are they strong enough to push for? If you see now, one of the most visible awareness campaign is a no-fall campaign funded by a pharmaceutical company. You saw this, if your face will look this way, instead of your liver, using some ACT UP language. They're sharing plow. You cannot see anywhere the word sharing plow. That is incredible, the most widespread awareness campaign. So in a way, there's not enough pressure, I believe. And that's probably a good question also in terms of community, how to build a real community around drug use and push in the same way very effectively, the gay community and other, that really, build up real sense of community did in terms of pushing for good drug for HIV and AIDS. That's probably one of the other explanations why there's not much research and why we have to see this awful campaign funded by a pharmaceutical company want to put everybody on treatment because, of course, they sell drugs.
Okay, and the last question, Konstantin, that has?
Yeah, very quick, Raminta. The question is about, maybe due to my information and feedback from Ukraine, it's, given the resources, what would you choose, I think, of substitution drug, buprenorphine or methadone? Well, there is no such diversion. The effective substitution treatment program should have both. But if we speak about based on the resources, and I said this, that and it's even cited in all the strategy that without access to methadone right now, there is no scale up, and we will not reach the indicators of the Global Fund, and we will not. Methadone is the cheap, effective drug. I do not know, but for sure, advocacy for price reduction for buprenorphine should be done, and buprenorphine should have its place, also taking into consideration that it's more widely could be accessible because of its classification. But right now, the methadone is approved as a really cheap, effective, very easy to scale up medicine. In terms of IRV, there are also things maybe we can consider, but I will not step on this. This is about interactions, IRV, methadone. But it's also not a problem both for buprenorphine and methadone.
Can I make just a short comment about this issue about diversion? I think that the best answer I've heard about this question was in a conference in Ukraine from a French doctor was saying, well, it's true. In France, it is estimated 10% of buprenorphine is diverted. So what? So benzodiazepine are diverted every single day. So 10% mean that 90% of the patients are treated. So that's really a non-issue.
Yeah, I wasn't speaking actually about this, Maura, more about the access to, to prescribe by any doctor, so part of general health care, which gives certain, but I also will cite, following up, because it's a very important issue on buprenorphine, is that, for example, in Ukraine, by 2003, the total amount of the whole amount of drugs illegal were 27 tons taken 1 year. That's one report. And when there were debates about buprenorphine coming and starting this very limited 7 sites, the whole amount of buprenorphine was, I don't know, around 3 kilos. So if it all will be diverted, how it will change the drug market? So what? 300 kilos? Come on.
Okay, I won't add anything. And we will have the last question, and we will close the session in like about 5 minutes. Please, could you introduce yourself?
Bruce Marshall again. Methadone and heroin, they go together. We've talked a lot about this. I would like to know what role is played by cocaine in Europe, in Eastern Europe, and certainly cocaine is a big problem in the injection drug use business here in Canada. And of course, there is no substitute drug for cocaine as there is methadone for heroin.
I will speak about Eastern Marok instead about Western Europe, but also the data. It's the hugest Western European epidemic of cocaine use. But in Eastern Europe, I mentioned that the changes in the drug scene, and particularly the cheap amphetamine market, powder market is coming, and it should be definitely addressed by harm reduction. Cocaine we do not have huge market for cocaine, both because of economic reasons, logistical reasons, so it's still limited to the certain groups as it was maybe a decade ago in Western Europe and in Canada. But cheap access to cheap amphetamines, powder amphetamines are really a huge wave, especially among young injectors. Plus to this we have homemade super active amphetamine, which is only injectable solution form called Pervitin, which is really is not addressed by any types of comprehensive care for users, which are still on embryon stage. And for this, one of the important issues that we are advocating for is to add the psychiatric care component and counseling to the comprehensive care model.
Maura, do you want to add something about that? No. I will just add that there are some issues that address about cocaine and stimulant use in the book that was released actually today, Delivering HIV Care and Treatment for People Who Use Drugs. And there are some examples how it might be delivered. And those examples are not only from developed countries, rich countries, but also from Latin America. And Latin America, as we know, had huge epidemics related with injecting drug use and with drug use, with cocaine actually use. And
yeah,
here
I would recommend this. Both alcohol, crack, and cocaine issues are very much presented there.
And this book, we can make available. I will repeat. The book is available downstairs in the exhibition hall, the booth of the Open Society Institute. And we can try to make some books available for the next session, which will be again on injecting drug use, on harm reduction evidence, and which will be taking place here in half an hour, the same room. And using an opportunity, I also wanted to make one small announcement related to harm reduction. And as we know, harm reduction needs a lot of support of different people. And one of the issues that we want you to help us with is this Declaration of Unity, which identifies key issues that we should challenge our governments, ourselves, including harm reduction programs and also UN systems. These declarations will be available here, and they are also available, I think, that in OSI booth and also in the networking zone on harm reduction in the Global Village. Thank you so much. And the last announcement, sorry, the last announcement is you see those beautiful T-shirts on these three beautiful people.
We are not twins, no. Just a
and if you wanted to support the group, which is called Front AIDS, and to buy T-shirts, contact either Sasha or Konstantin here. And also, if you had any additional questions, I will ask speakers to be here around at least for 5 minutes. So if you want it, just please come here. Thank you. And this is really everything.